Hello, and welcome to POMA Does, a podcast produced by the Pennsylvania Osteopathic Medical Association. We provide a voice for osteopathic medicine and share insights on issues important to osteopathic physicians, residents, and students, as well as those who embrace the osteopathic philosophy. POMA's mission is to promote the distinctive philosophy and practice of osteopathic medicine for our patients, our members, and the communities we serve. Thanks for tuning in.
Hello, and welcome to the latest episode of the POMA Does podcast, sponsored by the Pennsylvania Osteopathic Medical Association. I'm James Zervios, Chief Operating Officer of the Obesity Action Coalition, or OAC. I've been with the OAC since the very beginning in 2005, and my passion has always been helping drive real change for people living with the disease of obesity. I am extremely excited today to join Dr. Christopher Still to talk about obesity and weight loss. Obesity is a complex chronic disease, and sometimes lifestyle changes on their own just aren't enough. In those cases, FDA-approved weight loss medications can be a helpful tool, especially when used under the care of a healthcare provider. I'm really looking forward to our discussion, but before we get started, I do have a couple of notes. First, this podcast episode is eligible for CME credits. To claim your AOA Category 1B credit, visit the webpage listed in this episode's description or visit the POMA Does podcast page on the POMA website. Lastly, this episode was developed entirely by POMA. Dr. Christopher Still, faculty for this educational event, is an independent contractor and consultant, serves on the Speakers Bureau for Novo Nordisk and Eli Lilly, consults for Boehringer Ingelheim and Curax, and is a contractor for Ethicon Endosurgery. I, James Zervios, along with the planners for this episode, have no relevant conflicts of interest to disclose. All right. With that, let's get started with today's episode. Welcome, Dr. Still. How are you?
Hello, James. It's so good to be with you again.
It's amazing to be with you. And I don't think folks know that you're actually one of the individuals that started OAC in 2005, before 2005. So what we are today, much of that credit goes to you, and we appreciate that.
My pleasure. You guys have done extremely powerful and important things, and that's why I asked you to join me today.
Well, thank you for that. And you know, thinking back 20 years ago, the disease of obesity was looked at very differently. I actually don't even know if it was really considered a disease in many spaces. How would you say things have changed, you know, over the last 20 years with obesity specifically?
Yeah, that's a very good point. It was not considered a disease. And unfortunately, some people even today don't view it as a disease. But I think the driver of the success that we have all made is really more effective treatment options, to be honest with you. Yeah, and bariatric surgery. I think those two modalities, treatment modalities, has really made obesity the disease it deserves. But we still have a long way to go for sure.
Yeah, and we talk about those treatments, bariatric surgery, and now today there's, you know, so many of the popular GLP-1s that are available or on the market, I should say. But we still deal with a very strong access problem when it comes to these medications for patients.
Yeah, and multifactorial access problems. You know, the cost right now is prohibitive for many individuals. Coverage is limited for individuals. You know, it's interesting. I don't know if people know that less than 2% of patients that meet the criteria for anti-obesity medication and bariatric surgery, for that matter, actually are prescribed or undergo bariatric surgery or pharmacotherapy for the treatment of obesity. So although we have very successful and effective treatment modalities, we have a lot of opportunity, if you will, for patients to get access to these very effective treatment modalities, as you know.
Now, for patients that they're still struggling trying to access these medications or bariatric surgery, you know, we at OAC, they often contact us and they say, well, what can I do? How can I advocate? But in real world practice, what do you do for a patient that can't access them? Do we lean back into the behavioral approach for weight loss?
Yes. I mean, that's basically what we have. There's more coverage for bariatric surgery to date than there is for anti-obesity medications. And so if they qualify for surgery, and, you know, we give them, I always give patients all their options when I first meet them, you know, because they'll say, oh, I'm not interested in that. But given the limited success we have over time with just diet and exercise, often we are then looking at pharmacotherapy and or bariatric surgery. So that's how I usually do. We always start with diet and exercise and behavior modification, but most times we need to go beyond that. And I think that's a very important point about realistic expectations. By and large, diet and exercise, we can produce about 3 to 5% of weight loss after 1 year. Some people lose a lot more, some people lose less, but it's about 3 to 5%. So if we have a patient that needs to lose, greater than 3 to 5%, then we should look into anti-obesity medications and or bariatric surgery. Then we go into that. Is it covered? Is there access barriers? What? But that's how I sort of look at things when I first meet a patient. I make sure that we always stress diet and exercise and behavior modification, and then other treatment modalities that they have access to.
Now, talking about the treatment, to pivot for a moment, you're one of the foremost experts in obesity medicine and treatment, right? Everybody knows Dr. Still. They know you, they know what you do. And I think, you would be gold standard for how you would take care of a patient, how you would treat a patient. But what we've seen as the patient advocacy partner in this conversation is a lot of individuals, even going back to the early days where bariatric surgery was one of the primary tools and there wasn't much else available, that wraparound care didn't always exist. And we see that today too, where, someone will access a GLP-1. It could be a compounded GLP-1, which OAC has a strong position on compounded medications, but there's no post follow-up. There's no nutritional education. So, what are your thoughts on how to best approach the treatment of someone with obesity? I don't think a lot of people in today's society, I think everyone has been very influenced by the pop culture narrative of the GLP-1s and looking for that number, right? That expectation, that number on the scale to go down. But what does good care look like?
I think we don't know, to be honest with you, but I will just tell you that as the listeners know, these GLP-1s can and are very effective at patients losing weight. We tend to look at them like bariatric surgery patients, to be honest with you. If they've been on a GLP-1 greater than 6 months, we test for macronutrient deficiencies. Are they getting in a good diet quality? They're not eating as much, yes, but is their diet quality up to par? Are they getting enough protein and getting enough fluids? So we've sort of taken a quality improvement look at patients that are on longer term GLP-1s to see just that, like we do in bariatric surgery patients. 6 months, we do blood work for our bariatric surgery patients. It may be overkill. I'm not sure, but we've seen a lot of people lose a lot of weight, and I'm very concerned about their diet quality. Are they eating, a good diet quality?
One other aspect of this treatment plan that unfortunately doesn't get talked about a lot is the mental health aspect. Mm-hmm. And we deal with a lot of individuals who they may have experienced trauma at some point in life, and that's not necessarily worked out. And I think oftentimes people think, well, if I can just get on a GLP-1, everything will get better. All my problems in life will go away. Life is going to be perfect. But there's a big mental health gap when it comes to the treatment of obesity. What are some of your comments and thoughts?
Absolutely. And we know that it's very similar. It's identical really to bariatric surgery. People think, I just needed to get surgery and, everything will get better. Well, as it turns out, they still have their same spouse. They still have their same job. They still have their same, stressors. So you're absolutely right. I think we have this false unrealistic expectations that if we get on this medication, everything is going to be okay. And it's very similar to what we saw, like I said, with patients with bariatric surgery. So, there does have to be a good support group and psychosocial help in patients that are losing weight. We know that depression is much higher. As our body mass index increases, so does the rate of non-suicidal depression. But there are other factors that come into play that I think you bring up a good point, that just taking a medication and losing weight is not the answer for everybody.
You talked about the spouse and a little bit of that family dynamic there. And at OAC, we often see obesity as a family affair. And, just last year, OAC launched the Thrive Together program, which really focuses on youth and teens that are dealing with obesity. And that's a population that, I think it can be very tricky. There are people out there that feel, hey, we should not be doing bariatric surgery on a teen. We should not be prescribing a medication to a teen because, be it their bodies are still developing, they're growing. What is your clinical opinion, right? So if you have a child that's dealing with obesity, what is the approach that a parent should take with that?
It's a very good question. And for full disclosure, I have two other colleagues that head up our adolescent obesity program. But I will just say is that, at least in our patient population, they are, in addition to their obesity and their being bullied in school and all the psychosocial aspects that go along with that, there's a lot of disease burden to go along as well. Fatty liver disease in adolescents, obstructive sleep apnea. So I view that as, more of an intensity, and that these medications have been around a long time. Even the GLP-1s, believe it or not, have been around a long time, maybe for diabetes or other indications. But I do think that they should be considered. And I think that you have to weigh the risk benefit. But, and that goes along with bariatric surgery too. We do also do bariatric surgery in adolescents. It is very comprehensive, but we do have, good results. But we don't do a lot, but we do have that opportunity or treatment option for adolescents that I think is needed. Having said that, I think it's important to go to a center of excellence or a center that has comprehensive adolescent obesity programs.
You talked about a couple of things just now around the sleep apnea, fatty liver disease. In my work, I have definitely seen a little bit of a shift on corporate partners in this space where we're now looking at those things specifically. Yes, they're still looking at obesity, but how does this new medication treat fatty liver disease? How does it also treat obstructive sleep apnea, cardiovascular issues? What does the future look like in that respect for obesity treatment? I mean, I hate to say it, but speaking to GLP-1 specifically, it kind of seems like every month there's something else that they're getting an indication for, right? So what does that future road look like?
So, I mean, as you alluded to, I'm an old guy and I've been doing this almost 30 years. But I will say that the GLP-1 is really a game changer for cardiometabolic disease. I liken it to statins for, cholesterol, or SSRIs for, depression. So I think that it does have a lot of metabolic benefits. And I think that we've seen in the SELECT trial for cardiovascular improvement, even in the ESSENCE trial that was just published for semaglutide for fatty liver disease, these benefits are independent of weight loss. So I think that they do have independent improvement in cardiometabolic disease. Having said that, I think that we need to look realistically at these medications. I mean, they are very effective, but, there's some side effects. There's some contraindications. Someone with medullary thyroid carcinoma should not be prescribed personal or family history. The history of pancreatitis of unknown etiology. There's side effects that need to be dealt with. But you really have to weigh the risk benefit of these medications. So I do think it's been a game changer. I do think that indications sometimes are driven by reimbursement. So if there's not going to be reimbursed for the treatment of obesity, maybe we can get it for the treatment of moderate to severe obstructive sleep apnea or, hepatic fibrosis. So it'll be interesting to see how the landscape changes with all these indications. I mean, they're looking at it for substance use disorder, for Alzheimer's, many, many indications, as you said, they are looking into.
When we talk about the treatment landscape, I just had this question asked to me the other day, and they said, how has that changed, from when OAC started to now? And I said, well, when OAC started, there was bariatric surgery. There were some medications that came on the market, were pulled from the market. But today, there are oral medications for obesity. There are the GLP-1s. There's bariatric surgery. And then even ESG is another procedure now. And I don't think a lot of people know about ESG. Can you talk about that a little bit, what that is?
Yeah, endoscopy gastrectomy. So yes, it is a sleeve gastrectomy that is done through an endoscopy. So they go in and they run a series of running sutures, if you will. So they make a sleeve endoscopically rather than laparoscopically. So we just started that here at Geisinger. Dr. Kara has done, I think, 6 cases. So yeah, again, reimbursement is the biggest issue right now. But I think as that treatment modality grows, payers will come into that as well. I don't know if we know the long-term efficacy of that, but I think that's why you do it and see, the ban has come and gone as well. So I think in the long run, we're going to have to see the efficacy. But right now, the Roux-en-Y gastric bypass and the laparoscopic sleeve gastrectomy remain the 2 most common bariatric surgery, but the ESG is definitely becoming more common, especially at the larger institutions.
Like I said, I think there's this assumption sometimes because so many people are now thought to be on a GLP-1 and the media talks about it, that there's just thousands and thousands and thousands of healthcare providers that are trained in this. And there's not. I mean, you know that very well. And with that being said, I sometimes get a little bit discouraged when I see the narrative present itself in the societal space and the healthcare societies around this or that. So pitting one treatment against another. And I know you're a big proponent of we need to work with whatever's going to be best for the patient. So in your eyes and in your treatment or the way that you approach treatment, how do you encourage a patient to understand that they don't have to choose just bariatric surgery? Maybe they are post-surgical and they've had some weight regain and now they need something to help them. But how do you approach that?
Yeah. So obesity is a chronic relapsing disease, and it doesn't really matter if you've had bariatric surgery or pharmacotherapy. You're going to need comprehensive long-term care. And I think we've seen that in patients that don't have that in bariatric surgery, and even patients that do have comprehensive care after bariatric surgery. And it's one thing I want to point out that is no fault of the patient. It is not that they're not eating the right thing or not exercising much. It is the biology of obesity and weight regain. And so, there's hormonal factors that go in with when we lose weight, either by medical or surgical weight loss that come into effect that have us gain weight. There's metabolic adaptation that our metabolism actually decreases, unfortunately, to promote weight regain. So I think that's one thing that it's important for me to tell patients that it's not their fault, number one, but early intervention is very important. You don't want to wait till patients gain all their weight back to start an anti-obesity medication or weight pharmacotherapy. So you want continued accountability and follow-up. But you're absolutely right. Just because you've been on one, it doesn't exclude you to the other. We use a lot of pharmacotherapy preoperatively in our bariatric surgery program, and we use a lot of pharmacotherapy postoperatively in our post-bariatric surgery folks. I always say 9 months after surgery, everybody's a medical management patient because you need that continued accountability, because the longer you follow, you're going to see postoperative weight regain. And really, that's the same with medications as well. We change medications after a while if they're not effective, just like blood pressure, just like treating blood pressure. We add things, we add medications or, change medications. So all that, I think, to your point, and I'm biased, but I think that's why going through a qualified physician or healthcare provider for your treatment of obesity and comorbid medical problems is really going to do you a lot better than just getting these online, because there's a lot of things that can happen and should be monitored with GLP-1s and obviously after bariatric surgery.
I wouldn't call you biased. I would call you correct. I think it's a very true statement. And I think it leads me to my next point, where a lot of people today, because of, I think, just the mindset we've always had with obesity and it not being a chronic disease, right? So we try to educate so much that it is, but there's this mindset of, if I get on a medication, I lose the weight, I can just stop the medication and I'll be fine. And yet a lot of the research shows that no, this is chronic. Like, you may not be on that specific medication or that dose, but you will be on something, because we don't stop blood pressure medication, right? So, I mean, how do you kind of explain that to a patient who might have that mindset that says, hey, doctor, so when I get down to X number, I'm good, right? But you go, no, that's now.
I just need a jump start. I just need something to, yeah. I mean, it's not the patient, it's the payers. It's everybody thinks, well, how long do I have to be on it? And I always say, just like you said, well, how long do you have to be on your diabetes medication? We know any chronic disease, once you stop that treatment modality, You're going to regain your weight. Your blood pressure is going to go up. Your blood sugar is going to go up. However, because the GLP-1s can be so effective in losing weight, there is a 80% or 75% of patients will gain back their weight within 1 year with abruptly stopping these medications. So I think that is really an important point that I make sure patients, because it's a waste of money. It's a waste of the psychological psyche of patients losing weight and gaining it back if you only think that I'm only going to be on it, X amount of time. So I think you bring up a very good point. And for the first time ever, we get people down to their ideal body weight with medications. I mean, I've never been able to do that in the past. And so you can't stop it. So you have to wean the dose down or maybe even extend from a week to every 10 days or 2 weeks because, and that's the science of the treatment of obesity, with the GLP-1 specifically, because if you stop it, you're going to gain your weight back. And I think that the insurance companies that change criteria and don't grandmother or grandfather patients in and just abruptly stops, it's a travesty. I mean, it is a travesty because we know what's going to happen. We know the psychological, burden that's going to put on the patient, but it happens every day. And so we do try to work with other medications, other oral medications. And the other thing is, I don't want to poo-poo the oral medications. There's very safe and effective oral medication. The big buzz right now is the GLP-1s because of their efficacy. But there are great oral medications out there that we prescribe every day. And so I just want to put that out there that this should not just be about the GLP-1s. There's many tools in our toolbox to treat the chronic and relapsing disease of obesity.
And you brought up one point that I want to touch on and another point, and you talked about people losing coverage every single day. And OAC is active right now, I think, in more than 35 states throughout the U.S. and on the federal level in protecting access to care and coverage. And because you're spot on, insurance companies are now playing doctor. They're dictating healthcare, right? And that's not how that should be. You popped something else up in my head when you were talking, I'll talk dollars for a second. We see this like knee-jerk reaction on Wall Street when a pharma company publishes results of a study and it doesn't beat out the best percentage we have now. So if the pharma results don't show 50% weight loss, their stocks plummet. And it's this odd setup where Wall Street has this knee-jerk reaction, but I don't know. I mean, you tell me, I don't think most people have like 40% weight to lose. I mean, at what point do we say, hey, that's a good percentage and we got to stick with that?
It's so funny you said that because I was at a meeting and somebody said they're only getting 15% weight loss. And I said, stop right there. Just think of what you just said. I mean, we've been doing this 25 years. Remember, some of the other medications were 5 to 7 to 8% weight loss. If we hit 10%, that was a rock star. Now we're poo-pooing 15% weight loss. So that's where we've come. So, I mean, it's a good thing, but I just think people need to realize that 15% weight loss, anything above 10% from a medical standpoint is significant. Yeah, some people may need to lose more, but I agree with you 100%. And just to think what we've come, you don't need to lose 25% in most individuals. That's why we need to be cognizant of who we start on these medications because you're going to be weaning down faster than you're going to be titrating up in a lot of individuals. So you're absolutely right. And so I don't think everybody needs a GLP-1, to your point. That's why I think going to a comprehensive weight management program that will, meet the needs of that patient. Maybe they need bariatric surgery and pharmacotherapy that you alluded to earlier. So I don't think they're all one size fits all, if that's what I said, if that makes sense, because yes, they're effective, but they're not for everybody for a variety of reasons.
Dr. Estelle, I think that is a perfect note to conclude this podcast on. There is no one-size-fits-all approach, and that is something that you taught us at OAC very early on, right? We said 20 years ago, you educated us on the fact that obesity is a disease. There is no one-size-fits-all approach. It's complex. There's a lot of facets to it. And I really think that if we could encourage that level of thinking, right, with not just healthcare providers, but patients, payers, and everybody in between. There's so much more success that we could see. So this has been an unbelievable opportunity. I really enjoyed getting to talk with you today.
James, it has been a pleasure. And before you sign off, can you just give a few sentences about the OAC? Because you have a wealth of opportunity and educational materials at the OAC that I think that would be remiss if we didn't bring that up.
Yes. So for those that are not familiar, the Obesity Action Coalition is a nonprofit patient advocacy organization. We have more than 90,000 members nationwide, and we operate on four main principles of education, advocacy, awareness, and support. So thank you so much, Dr.
Thanks, James. It's been a pleasure.
All right. Take care. Goodbye.
Bye.
Thank you for joining us for this edition of POMA Does. Be sure to subscribe to POMA Does wherever you listen to your podcasts, and tell your friends and colleagues to tune in. Learn more about osteopathic medicine and POMA on our webpage, www.poma.org, and join the conversation on social media. We're on Facebook, Instagram, LinkedIn, Twitter, and YouTube. Or email us at poma@poma.org. We'd love to hear from you. Join us next time for another edition of POMA Does.